Good morning, everybody. We'd like to welcome you to this interesting session. I hope you all had breakfast with eggs because we are now making the walk on the shells and seeing what's happening here. For those who haven't met me yet, I'm Malaika Mendonça. I'm consultant in a PICU in Bern, and my co-chair Hannes introduces himself.
Hi, also from my side, thank you for being here in the morning. My name is Hannes Salmon. I'm a pediatric cardiologist and I work in Graz, Austria.
So we are excited about this interesting morning challenges, and we want to see how Angelo is balancing on the shells. Angelo Polito is leading the PICU in Geneva Hospital. He is also gets a lot of credit for organizing this interesting part of the conference, the cardiac track, and we are very happy to have you here to tell us about preoperative management of the neonatal congenital heart diseases. Thank you, Angelo.
Much. Thank you. So this is can you hear me? Yes. This is a very interesting topic, but it can be challenging when it comes to a systematic approach of these children in the pre-operative setting. So I think that the best way to approach those kind of clinical issues is to rely on physiology. And then it's the same approach that has been used in this very interesting paper from Ashrafi that I would suggest you read it carefully. So there are probably 7 overlapping physiological patterns that we can identify. And then they are not, of course, not mutually exclusive, so you can have one patient with 2 or 3 of those patterns. And then those patterns are represented by the systolic dysfunction, which is probably the less likely in the preoperative setting of neonates, diastolic dysfunction, excessive pulmonary blood flow, obstructed pulmonary blood flow, obstructed systemic blood flow, transposition of the great arteries, and a single ventricle. So the problem with the systolic dysfunction in neonate is that they are not equipped for as in adults. So the contractile tissue is less important because there's more collagen, more fibrosis, more connective tissue into the myocardium. So usually these hearts are less compliant, and then they are more afterload sensible. They are not able to cope with increased afterload because of less contractile tissue, and then because of a decreased compliance and an increase in diastolic dysfunction, they are also preload insensitive. In fact, if we look at the famous Frank-Starling curve, where you have a cardiac output in the y-axis, and in the x-axis you have the preload, adults are here and newborns are usually there. So giving fluids to newborns are not really always a good idea. And then what the neonates and what we should do in order to increase the cardiac output in those children. So one thing is to increase heart rate, and this is up to the baby, and then they always do that, and then we see it in the clinical settings. The way they increase cardiac output is to increase heart rate. And then the other thing is that we can, as clinicians, trying to counteract the limited L-type calcium channels in inefficiency by giving them some extra calcium to increase the extracellular levels. Pattern number 2 is diastolic dysfunction. So we can find it in the classical patient born to a mother with diabetic problems and then with left ventricular hypertrophy and congenital diaphragmatic hernia, and of course in those in congenital heart diseases that are characterized by the presence of valve stenosis and Pompous disease. Of course, there is another very rare condition characterized by diastolic dysfunction. What's the problem here is that again, the neonatal myocardium is not very efficient when it comes to the uncoupling of myosin and actin, and then this contractile apparatus do not do that very efficiently. So, and the reason is the immaturity of the sarcoplasmic reticulum, and there is no, or less than in older children and adult, there's less myocardial relaxation. So the heart becomes stiff. So what we can do about it? So judicious, very slowly, we can give some fluid resuscitation because we already know that they are placed in the right part of the Starling curve. So we can try and see whether a very small amount of fluid resuscitation might help reducing this contract, the stiffness of the myocardium. Sometimes, in very extreme cases, beta blockers like very short-acting beta blockers like esmolol might be a possibility because, of course, reducing heart rate increases the filling time. But we have seen also that decreasing heart rate is not a good idea in neonates because that's the way they increase cardiac output. So all those therapeutic possibilities has to be carefully weighted before implementation. And then, of course, if you have congenital stenosis of the valves, you have to think about relief of the obstruction quite rapidly. So pattern number 3 is excessive pulmonary blood flow, and of course this is physiologically represented by a left to right shunt, and this implies, of course, a mixing of oxygenated and deoxygenated blood. What is the problem here? It's not really the increase in blood flow, in pulmonary blood flow, but it's the decrease in systemic blood flow. So, of course, this is a simple physics. If the QPQS is elevated, it means that your patient is theoretically exposed to the possibility of a very poor systemic perfusion. What are the classical congenital anomalies associated with excessive blood flow? This is a balanced atrioventricular canal, or for instance, you have a tetralogy of Fallot with pulmonary atresia and VSD with MAPCAS, with those nice collaterals that bring oxygenated blood from the aorta to the pulmonary circulation, and then thrombosarteriosis. So those are the three of the most frequent congenital heart disease associated with this physiological pattern. What we can do about it? So, of course, do not harm. So, trying to avoid, whenever possible, vasodilators, pulmonary vasodilators like supplementary oxygen, and avoid the systemic vasoconstriction because it facilitates it increases, of course, the pulmonary blood flow. And then sometimes we use continuous positive airway pressure in order to counteract the increased pulmonary blood flow. And then if the patients are intubated, then you can use permissive hypercapnia in order to decrease the PCO2 and again counteract and vasoconstrict your pulmonary circulation. Systemic vasodilation, maybe. I'm not personally very convinced in this kind of patients, but from a theoretical point of view, this is something that you can explore. Another pattern, which is obstructed pulmonary blood flow. So it depends on the level of the obstruction. So if you have a mild stenosis of the pulmonary valve, or you have a pulmonary atresia, it's different. So you can of course observe the patient and see how it goes, or you can need to pass from simple observation to the use of prostaglandins because the pulmonary blood flow is insufficient and the patient is highly hypoxemic and cyanotic. There won't be differential cyanosis in those patients because, of course, the pre and post ductal saturation will be the same. And again, what can we do about it? We can try to play with vascular resistance, optimizing pH, trying to taking care of airway patency, and then that is easier said than done, but we should strive to ventilate patient at FRC, which means avoid overdistension and the recruitment, but nobody is able to measure FRC at the moment. And then, of course, if there are no residual obstruction, you can try to use vasodilators and supplementary oxygen. So this is the special case of the pulmonary atresia with intact ventricular septum. And then maybe you are already aware of the right ventricular dependent coronary perfusion, which is a condition characterized by the presence of stenosis, proximal stenosis in the coronary artery, and the presence of fistula between the RV and the post-stenotic coronary vessels. And that means that if the coronary perfusion depends on the right ventricular pressure. So if you are not aware of this possibility and then you open up the right ventricular output tract, you will decrease suddenly the right ventricular pressure, and your patient would be exposed to a sudden decrease in coronary perfusion with the risk of a cardiac arrest. Those patients are managed with prostaglandins, and then sometimes, like in the US, I think you have a very short waiting list. So those patients are put on prostaglandins and listed for heart transplant. I don't think in Europe we have this possibility. So be careful of what, so discuss with your cardiologist if you have this kind of situation. And then this is the Epstein anomaly, which is a very rare, let's say, tricuspid valve insufficiency. And then when you have these patients with a severe tricuspid regurgitation, you might risk what is called a circular shunt, which exposes the patients to a low cardiac output syndrome and desaturation. What is the mechanism? So the pulmonary, the blood from the PDA comes down to the PA and back to the RV. Because of the tricuspid valve dysplasia, the regurgitation of the blood allows the blood to pass through the ASD and then back to the LV and in the aorta and the PA and PDA again. So this circulation do not allow oxygenation and do not allow a correct LV output. So the patient is often desaturated and very badly perfused. So what we can do about it, so we can stop prostaglandin, and then we can maybe ask the surgeon to close the PDA in order not to allow this back draw passage of blood from the aorta to the PA. And then in other cases, you can try and see whether pulmonary vasodilation might also facilitate blood flow instead of a PA regurgitation. Obstructed systemic blood flow, this is very common. And then again, what is the degree of the obstruction? This is the first question. And then the classical, the typical case is the coarctation of the aorta, the baby with an acute closure of the PDA, which presents with multi-organ failure, very badly perfused. Or you can have a very mild aortic stenosis. So it depends on the degree of the obstruction. And then again, you can observe the patient, or you might need to use PGA, for instance, in cases with interrupted aortic arch or coarctation of the aorta. The idea will be to use the lowest possible dose of prostaglandins in order to avoid the side effects associated with prostaglandins. And in this case, someone likes to monitor differential cyanosis. That means pre-ductal saturation high and post-ductal saturation low, in order to monitor the patency of the PDA, but it is debated. So again, those patients in some cases might present with multi-organ failure, hemodynamic instability, and congestions, and then what should we do? I think if we are in doubt, let's give prostaglandins to those babies if you don't have the chance to have an echo and to rule out a congenital heart disease. In case of hypertrophic left ventricle from diabetic mothers, again, judicious fluid resuscitation, we should be aware that in this case, the use of inotropic and chronotropic drugs might facilitate the development of subaortic obstruction. You might consider the use of beta blockers, because in those patients there are also diastolic dysfunction, which is associated with that, and the increase in heart failure, in heart rate, might worsen the subaortic obstruction, and the use of prostaglandins in very extreme cases. TGA, two circular, so the aorta coming off the right ventricle.
You have to point here when
the right, yes, sorry, the right ventricle coming off the aorta, the aorta coming off the right ventricle, and the pulmonary artery of the LV. So you have two parallel circulation, and then this is the problem. So there is a mixing, there is two separate physiological situation, is a high QPQS and a very cyanotic patient. And what is the key in the treatment of those kids? It allowing mixing, which is not the same as shunting. Shunting is the passage of the blood from one side to the other, and mixing is the bidirectional passage of blood from one cavity to the other, in order to allow the oxygenation of deoxygenated blood and the perfusion with systemic circulation with oxygenated blood. So what are the mixing? Where do those babies mixed? So usually it's the ASD, and during the first 2-3 days, when the pulmonary resistance are still high, you can imagine that the PDA is still a mixing site. But when the pulmonary vascular resistance drops, and then your PDA is not a mixing site anymore. So what we can do about it? Of course, we should keep the PDA open. Sometimes fluid resuscitation is good because it allows the stretching of the atrium, and then indirectly increase the size of ASD. And then, of course, the rescue procedure. I think everybody is familiar with that. If pre-ductal saturation is low, which is in few words, you might want to increase the size of this communication here by sticking a balloon into the left atrium, and then you pull very violently here in order to break the interatrial septum. And then, if it's successful, usually you should be able to stop prostaglandins afterwards. Single ventricle physiology, I'm not going to talk about it a long time, because the next speaker will be presenting the challenging issues in the management of those kids. So here again we have one ventricle taking care of two circulation, which is the systemic circulation and the pulmonary circulation, and then the saturation in the pulmonary. the saturation in the aorta is the same as in the pulmonary arteries. This is one of the main characteristics of those patients. And then again, high QPQS, that is low systemic perfusion. So, in few words, how do we approach the pre-operative management of those kids? Usually, they are very good at managing their own vascular resistance. So, whenever possible, I think we should allow those babies to breathe spontaneously because they are very good at it. And then if we impose our own vision of how they should breathe, we might end up with a lot of troubles. It is theoretically possible to measure preoperative QPQS, but I don't think it is useful in the clinical settings. Better is to monitor end organ perfusion, if possible, mixed venous oxygen saturation, acidosis, lactate, etc., etc. Hemoglobin, I'm not going to be very strict about it because, as we said yesterday, guidelines are not very useful, but at least 9 grams of hemoglobin seems to be reasonable. And the one point which is key, I believe, in the management of those kids is that make sure that the ESD is not restrictive. This is the key point when it comes to single ventricle, preoperative single ventricle management, because of course it depends on the side of the hypoplasia. Let's say that you have, as in this case, left ventricular hypoplasia and you have a restrictive ASD, you cannot survive because you have left pulmonary congestion, low cardiac output. So first thing is make sure your ASD is not restrictive. And then there is a huge literature about, not huge actually, but a huge debate about how you should feed those kids. I think the truth is in the middle, so maybe we should feed those kids as much as they want to be fed. And last slide, and then I'll be finished. I think the neonates with congenital heart diseases are quite forgiving. So there are very few real emergencies in this field. I think that one of those is the TGA physiology with no or a very restrictive ASD. Again, a hypoplastic left heart with a restrictive or non-existent ASD, but you should be able to know it beforehand because in the prenatal diagnosis, you should be able to identify those problems. And the last situation is the total anomalous pulmonary venous, So total anomalous venous return with infracardiac collector, which is, it means that the pulmonary venous return is obstructed. Those are, in my opinion, the real emergencies. Otherwise, you can easily manage those patients without a very aggressive therapeutic measures in the preoperative setting. Thank you very much.
Yeah, thank you very much, Angelo, for this excellent presentation and giving us an overview on neonatal and preoperative management of neonates with congenital heart disease. Are there any questions from the audience?
Come forward.
Dr. Clausen from Berlin.
Thank you for your talk. Hello? Yeah. Just one question to the heart rate of the neonates, because everybody tells us that they need the high heart rate to produce cardiac output, but in clinical practice we sometimes see that children, especially with pulmonary hypertension, profit from lower heart rates. So counterintuitively, if you give beta blockers in those children and bring down the heart rate from 170 to 120, they show a better cardiac output. So that doesn't fit that much with the force frequency relationship that we postulate in the neonate, so maybe they can augment their contractility, not that much in high heart rates than we expect. Yeah.
Yeah, I agree. This is those indications are not set in stone. This is a very theoretical comments from my part. I mean, neonates increase heart rate by increasing cardiac output by increasing heart rate. That being said, I think those physiological patterns are overlapping. So if you have, for instance, a mild degree of diastolic dysfunction, that one possibility where those kids might benefit from a lower. And then the other thing, actually, if you have a high afterload, like in pulmonary hypertension or in very, very vasoconstricted children, I think a lower heart rate might benefit because you allow your heart to empty. You give more time to your heart to empty, and then you reduce indirectly your left ventricular and diastolic volume. But again, this is very theoretical. Then you are at the bedside and you see by yourself what's happening. And sometimes it's counterintuitive, but if it works, it works. This is my opinion. So.
Yeah, that was my question to you too. When you think you lower the heart rate, do you think it's because then there's more increase in contractility, or do you think the relaxation time, as Angelo said, and the time to empty the heart is the key point?
Yeah, I'm not sure about it. Maybe it's augmented preload also in that setting.
Yeah.
Maybe the time is too short with that high heart rate to fill the right heart. But maybe it's just the time that the right ventricle gets to empty.
to
So
empty,
I can't discriminate
Yeah.
between both. But it's just an observation that some children do profit from lower heart
Lower
rates.
heart rate, definitely. There was another question.
Yeah. So I was wondering about your thoughts about feeding the newborn with single ventricle physiology.
Yes.
Obviously, it's cyanotic. He may have compromised systemic perfusion. He's a neonate and he's on prostate. So
Yes.
4 major risk factors for
Should be scary, right?
encephalitis. So I'm wondering about your practice.
Our practice is the following. So we allow kids to eat as much as they want, but we are not imposing any extra nutrition by a nasogastric tube. So we did it because we went through the literature, and I think you did it the same. There's no evidence. And then actually we haven't had any problem with that. So no bowel ischemia before. And then we do this also for in kids with the coarctation of the aorta. We do the same. In the family of the obstructive systemic blood flow, we allow kids to eat as much as they want, but we don't impose any extra nutrition.
And then you add up with parenteral nutrition. Or what do you do?
Sorry.
You add up with parenteral nutrition? Or
Yes,
is
so,
this-
so
this-
we do like, it depends on the kids, 50-50, 60-40, and etc. And then it works. There are people feeding those kids 100%, and they don't report any side effects. So, I mean, everything is possible, even despite the risk factor that you mentioned.
And I'd like just to add to your comment that once Dr. Vernovsky said no single neonate will commit suicide with bottle of milk. So
Francesca.
What kind of milks do you use? Do you use hydrolyzed or
Mom's milk, yeah,
Yeah.
and if you don't have
if possible.
If you don't have mom's milk, what is it?
We used a regular zero formula milk, so we don't use it.
and you don't try to fortify it to make it like a
No, because I think we are afraid of making it hyperosmolar.
We have been feeding those children almost 25 years.
Yeah,
We have never had one case
yes,
of necrotizing.
yeah.
Feeding spontaneously or feeding within...
Feeding both spontaneously, we give what they want, and then we give extra
Okay,
via
nasogastrial tube.
I mean,
There is something called the prolacta. It is a breast milk banking. We use it in very critical cases like that. We import it from Texas, and we have a very good results, especially in cases just it is normal breast milk, and you can just only add very, very mild calories to it, and you have a very good results with this.
yes.
Yeah. One last comment, yeah.
Just to clarify, so when you say we feed those babies, we are talking about single ventricle physiology going to the...
Yes. Or obstructed.
Or
systemic
obstructed, like, yeah.
Just, I've seen problems with single ventricle, but hypoplastic left heart syndrome. And then, to me, the risk of one patient having an enterocolitis pre-op outweighs the risk of not feeding him completely. So if you have one enterocolitis, you lose one single ventricle. So that's my rationale. So I always fear to feed them too much to lose that enterocolitis.
And I just wanted to ask the audience one last question. The TGA, who has them on prostaglandin preoperatively? Most of you, huh? Yeah. Us too, and we have seen, especially in TGAs, more necks with preoperatively feeding. So I wonder if we do the right thing with the prostaglandin in comparison to the old days when we did a decent Reshkind and no child needed, or very little children needed to be on prostaglandin. So I don't know if your experience is rather the same. You fed the children on prostaglandin too, and you had no problems, yeah. And you, Ravi, you have more necks with prostaglandin feeding in TGAs, or?
Not particularly, I wouldn't say transpositions, but
Yeah.
any child who you have an open ductus with diastolic runoff,
With dietary, yeah.
potential risk for necrotizing enterocolitis. But we allow what's called non-nutrition feeding, which is really allowing babies to determine how much they want to eat themselves.
Yeah.
And we don't seem to, I think when you start fortifying and really pushing that nutrition enterally,
Then you have a problem, yeah.
Okay, thank you so much. And we move on with our next speaker, Kaylin Root, I hope I pronounced it correctly, from Boston Children's Hospital. She's a pediatric intensivist and an instructor of pediatrics at Harvard Medical School, and is going to talk about struggling to find balanced univentricular physiology in the post-operative period.
Thank
Floor
you
is
so,
yours.
thank you so much. I have no conflicts and no financial disclosures. I do have one disclosure, and that is that I am not Ed DeCruz. So if you looked at your initial program, you probably saw this man. But I am stepping in for him today, and so I'm going to try and do my best medical Ed DeCruz impression today. So today I'd like to talk about 4 things really in managing the single ventricle. So first I'd like to talk about defining what single ventricle means, the goals of single ventricle palliation, a little bit about our high-risk populations, and then management principles from Boston Children's Hospital's experience. So how do we define single ventricle? The physiology of a single ventricle patient applies to any cardiac defect where blood flow to the systemic and pulmonary circulations occur in parallel rather than in series. And so obviously this would cover a broad spectrum of pathophysiology. So some of those variations include the classic hypoplastic left heart syndrome with aortic atresia, which will be our case that we'll talk about today, but also right-sided malformations, including pulmonary atresia with intact ventricular septum and severe RV hypoplasia, tricuspid atresia, severe forms of Ebstein's anomaly, some heterotaxy syndromes with left or right isomerism, also unbalanced AV canal defects, double outlet right ventricle, and then also defects that have multiple VSDs. When we talk about the difference between anatomic and physiologic single ventricles, there are some cases where the degree of single ventricle physiology is determined by the presence of that shunt between the pulmonary and systemic circulations. So an example of this may be critical AS that has a PDA, and if the it may exhibit single ventricle physiology if the LV has low cardiac output, and so the RV is supplying the output to the aorta via the PDA. And these cases may have variable physiology over time. So the goals of the stage 1 single ventricle palliation, the first goal is to preserve systemic blood flow. We'll call this QS throughout this presentation. And I'd like to just shout out one of our illustrators at Boston Children's who did a great job. This is one of our illustrations that we use with our residents and fellows. And so I want to shout out Ms. Tang. So we do this through aortic arch augmentation, the DKS connection to combine both the aortic and pulmonary roots. And then at Children's, we also enlarge the diminutive aortic root in patients who have aortic atresia in order to preserve coronary blood flow. The next goal is to provide a calibrated source of pulmonary blood flow, which we'll call QP throughout this presentation, and that is to protect the pulmonary vasculature. The way that we do that is through an aortopulmonary shunt, the modified Blalock-Thomas shunt, or an RV to PA conduit. And then the last is complete mixing of oxygenated and deoxygenated blood, and we make sure that we have this with an unrestrictive ASD. Just wanted to touch on some of the high-risk populations. I'm sure many people are aware of the Pediatric Heart Network's SVR trial. The primary results for this trial were to look at the differences between the MBTT shunt and the RV to PA conduit shunt, but there were several secondary analyses that came out of this. And one of those was to look at risk factors that were associated with hospital morbidity and mortality. And so from that study, some risk factors for 30-day mortality in these populations were lower birth weight, lower gestational age, other genetic abnormalities, the length of the deep hypothermic circulatory arrest time, the duration of the total support time, failure to separate from cardiopulmonary bypass and needing to go on ECMO, an open sternum at the end of the palliation, and then the surgeon's stage 1 palliation volume. Other risk factors for hospital mortality in this population were needing a preoperative intervention on the atrial septum or Rashkin procedure, BAS, prior to going to the OR, and then younger age at surgery. So I'd like to talk about how we manage these patients at Boston Children's by using an index case. And this case came from a paper that was recently published last month in the Journal of Cardiothoracic and Vascular Anesthesia from some of our colleagues at Boston Children's who kind of went through one of our classic cases. So this is a full-term neonate who had a prenatal diagnosis of hypoplastic left heart syndrome who came to the CICU at 1 hour of life for management. They emerged vigorous with APGARs of 8 and 9 at 1 and 5 minutes of life. In the delivery room, the NICU team placed a peripheral IV, started prostaglandins, and brought the patient to the CICU. The postnatal echo showed hypoplastic left heart syndrome with some trivial mitral valve inflow and trivial regurgitation, aortic atresia, a severely hypoplastic left ventricle. There were no coronary artery fistulae. There was a large PDA with right to left flow in systole. There was retrograde flow into a moderate to severely hypoplastic ascending aorta, a restrictive PFO, and a dilated right ventricle with normal function. So preoperatively, Angelo, I think, did a great job talking about how we manage these patients. And for this patient, the course was notable for tachypnea with oxygen saturations that were in the mid to high 90s, but did not require any respiratory support or any hemodynamic support. Because of the restrictive atrial septum in this case, we did not feed this child. We put a UVC in and gave them TPN. And on day of life 4, they presented for their stage 1 palliation. So postoperative stage 1 management, really we're here to support the cardiac output and oxygen delivery as the neonate adjusts to their new circulation. Now that the single ventricle must supply both the pulmonary and systemic outputs, and we also have to manage some of the sequelae from their surgery that day. So that includes being on cardiopulmonary bypass, the aortic cross clamp time, reperfusion injury, and then a ventriculotomy if we're using an RV to PA conduit. Talking about the differences between the RV to PA conduit and the MBTT shunt, diastolic steel, which we've talked about with a PDA being open as well. If we are using a modified BTT shunt, the steel from the descending aorta and the coronary arteries could lead to inadequate end organ and myocardial perfusion. So something that you have to manage, knowing that neonates who have a modified BTT shunt are likely going to have a widened arterial pulse pressure. And then I'm going to spend the rest of this talk really talking about how we try, as best we can, to manipulate pulmonary vascular resistance and systemic vascular resistance. We know that the BTT shunt or the RV to PA conduit is a fixed resistance to QP. That's mechanical, and that's not going to change. And we need that to sustain the neonate through the interstage period. And so that means that likely QP is going to be greater than QS when we come out of the operating room. Not always. There certainly are times where we have to adjust that, but most of the time it's going to be a higher QP to QS ratio. And so we optimize various strategies to try to get that balance of the QP to QS and systemic output and oxygen delivery in that immediate postoperative period while trying to decrease the amount of pulmonary overcirculation. So some of the ways that we do that is by following to see if we have an appropriately limited QP. We look at that by basically at the bedside seeing if the saturations are in the 75 to 85% range and if our PaO2 is around 40. We also look for surrogates of adequate systemic output and oxygen delivery, including the serum lactate and arteriovenous oxygen saturation of 30% or less on average. Again, it would depend on what the patient's doing at the bedside, and preserving our end organ function. I know that milrinone is a hot button topic, so I just want to talk about systemic vasodilator therapy, and we do use this to decrease SVR and promote greater systemic blood flow. Milrinone has been shown to decrease SVR and improve oxygen delivery in neonates after the stage 1 palliation. And we also want to limit the alpha-1 adrenergic effects of a lot of our inotropes if they're at higher doses. So this is a study that was in the Journal of the American Heart Association by some of our colleagues at Boston Children's, including Ravi, who's in the room. So, and this was done by one of my colleagues. Kim Mills was the first author, and she introduced a milrinone-based vasodilator protocol in 56 patients between 2012 and 2015. 26 of them, I believe, were pre the protocol, and the rest were after this protocol, which was based on calculating SVR and PVR in the OR while coming off of bypass and adjusting the vasodilator therapy based on what the SVR was. And so used milrinone to decrease SVR, and in that sense, they were able to do that without an increased rate of serious hypotension, also with decreased lactate production, and a decreased incident of postoperative cardiac arrest. They also found that the relationship between oxygen delivery and SVR was inverse and nonlinear, and the greatest oxygen delivery occurred at an SVR that was less than 20 Woods units. And so when they were in the OR coming off of bypass anesthesia, calculated SVR, and tried to titrate milrinone to an SVR that was somewhere between 10 and 20. The manipulation of PVR historically has been attempted to help augment oxygen delivery. Ways that we've done this is by decreasing the fraction of inspired oxygen content, also hypoventilation, and also introducing carbon dioxide and nitrogen into inspired gases. Of course, as we all know, manipulating PVR has limited utility. The systemic to pulmonary shunt is the highest magnitude resistor, as I said, and it's fixed, so you can't really change that. And then also, systemic vascular resistance is order of magnitude higher than pulmonary vascular resistance. So even if you are able to increase your pulmonary vascular resistance, the manipulation of that doesn't often have enough of an effect on your oxygen delivery. We also have low cardiac output after stage 1 palliations. Vernosky and his colleagues showed that low cardiac output, defined as a decreased cardiac index with elevated SVR and PVR, occurs in about a quarter of neonates who underwent an arterial switch operation, and that peaks at about 9 to 12 hours postoperatively. And we know that low cardiac output syndrome also occurs in neonates following stage 1. So early recognition and targeted management of low cardiac output syndrome is critical in these patients. We do this via inotropy with beta-1 agonists, afterload reduction with systemic vasodilators, ensuring AV synchrony with adequate chronotropy. And then we also know that hematocrit is an essential component of oxygen delivery, particularly with our complete mixing lesions. However, as we've mentioned before, the lower limit at which oxygen delivery is compromised by hematocrit is not yet defined, and there certainly is evidence that shows that PRBC transfusions in these patients can prolong their ventilation time and ICU length of stay, so it really needs to be judicial use of packed red blood cells. There are studies, this came out of Children's Wisconsin and Milwaukee, that showed that lower superior vena cava oxygen saturations, i.e. a lower mixed venous, in the postoperative stage 1 neonates was associated with an increased postoperative morbidity and mortality. And if you have an increasing trend over the first 18 hours, that's associated with an improved survival and complication-free survival. So for our patient at Boston Children's, this patient had induction, intubation, and pre-bypass time that were all unremarkable. The stage 1 was accomplished with a composite Sano RV to PA conduit. We used a 7 millimeter femoral vein valved conduit with a 5 millimeter Gore graft. After separation from cardiopulmonary, or as we were coming off of cardiopulmonary bypass, a 75 microgram load of milrinone was given. We give about 25 per kilo. And then the patient was started on milrinone at 0.25 to 0.5, and that was titrated, as well as epinephrine. The post-bypass echo demonstrated a good anatomical repair. The chest was closed in the operating room, and he was transferred to the CICU for ongoing management. Cell saver and packed red blood cells were transfused throughout that initial postoperative course to maintain a hematocrit of 40%. There was an uneventful postoperative course. The patient was extubated on post-op day 5 and transferred out of the ICU on postoperative day 6. So hopefully I've touched on all of these things from the outline of talking about the single ventricle definitions, goals of the single ventricle palliation, our high-risk patients, and then how we would treat these patients at Boston Children's. I'm happy to take questions.
Thank you very much for this very interesting overview and sharing your experience. We are happy to take some questions for Kathleen. Yeah.
Gotta go to the mic.
Yeah.
No, in the microphone, please.
I think he has a loud enough voice, but yeah.
Thank you. That was an excellent talk. I just want you to comment on the postoperative inotropic combination that you use. You said milrinone. How much dose of milrinone, and what is your inotropic agent?
Yeah.
Epi, Lucan?
Typically, it's epinephrine. It'll often come out somewhere between 0.03 to 0.06, and we titrate the epinephrine. Occasionally, they'll come out on low-dose dopamine as well, but usually it's epinephrine with milrinone. In the immediate postoperative period, we will sometimes use shorter-acting vasodilators like nipride or nicardipine, just in the instance that the blood pressures may be low, just to not have the half-life of milrinone, and then add the milrinone in later as the patient settles out after that first 9 to 12 hours. But usually epinephrine is the beta agonist that we use.
And what's your typical dose of milrinone?
Usually 0.25 is what we'll start at, and then just up to 0.5 as they come out of that low cardiac output state.
And can you add on the sedation protocol that you use on this?
Oh yeah, absolutely. So typically we use dexmedetomidine and opioids. We avoid benzos as much as possible in this neonatal period. And so they'll typically come out somewhere between 0.5 to 1 of Precedex, dexmedetomidine, and then morphine between 0.05 and 0.1 mg per kilo per minute, or per hour.
Thank you very much.
Yeah.
Other questions from the audience? Yes.
So if I got it right, you are using in Boston Zanoshunt with an integrated valve.
Yes, we
Yeah.
do, yes, that's the most common.
Okay, and you do it for several years, or is it pretty?
I think we started it back in 2010-ish, so probably about 15 years we've been using that now. And the idea is that hopefully the runoff with a valved conduit will be less, and the volume load on the right ventricle will be less if we have a valved conduit.
And are there any dates that support that hypothesis?
You know, I don't think we've published on it yet, Robbie,
Okay.
if we have.
I don't think there's publication,
Yeah.
but largely it is to prevent pulmonary regurgitation that often happens in a non-valved conduit. And we hope that the RVPA conduit with valves preserve enough pulmonary blood flow so then the patients are a little bit older coming into a Glenn operation. But
I don't think we've published it.
Some of our surgeons do it a little bit differently, and that's kind of why we have 10 surgeons. Some of them do it a little bit differently, so,
Okay.
so yeah.
And one last question. My concern or my thoughts about Mirinone is often it lowers also the pulmonary vascular resistance. How do you know, does it affect pulmonary vascular resistance more if there is hypertension? Or so your data supports the usefulness of it for systemic vascular resistance?
Yes, it definitely, the data from our group, again, this was a population of 56 patients, and it definitely supported it. But I know it is as we know, a pulmonary vasodilator as well. But I think that overall the decrease in the SVR has outweighed the PVR.
Okay, thank you.
But yeah.
And so, go ahead, Peter.
Yeah, we have time.
Thank you, Kalen. So you gave a perfect example of how it goes, but it surely doesn't go always like this. So what are the problems that you run into?
Yeah. I think two of the biggest problems is we certainly in our modified BTT shunt population have had shunt occlusion, and so having heparin available at the bedside and ready to go quickly from our code cart is something that has definitely been, I've been there for a couple of chest openings, rapid chest openings for shunt occlusion, but we do more RVDPA conduits at our institution than modified BTT shunts. So shunt occlusion, and certainly I think low cardiac output syndrome has been, and trying to balance that high SVR with oxygen delivery tends to be what keeps me there at the bedside in the middle of the night.
Kate, and one question from my side. Sorry, you, come on. You said you calculate the systemic vascular resistance only in the OR and then start with Mirinone. But we all know the situation probably changes when the children come onto the unit. Don't you think it's worthwhile doing this calculation a bit more frequently, or have it automated in the electronic system calculated, that you see those changes and the trend in those changes? Do you have anything like this? Or?
No, when they did the protocol for the study, they did actually calculate it throughout. Every 4 hours, they were calculating a QPDQS and an SVR throughout the day. And so during
for the study, I was.
We don't do it automatically at the bedside anymore, and so it's basically provider dependent. But it makes a lot of sense. And where I also trained, as I said, in Milwaukee, Wisconsin at Children's, and they would calculate it more frequently throughout the. But I think following it, as we know, we've said multiple times about all of the talks here that the patient changes at the bedside, hour to hour, minute to minute. You know, so I think calculating it throughout, and that's one of the risks with Mirinone, is that you may change your SVR, but you have that in your system for the next 6 to 12 to 24 hours.
Yeah.
But
and that's different if you have nitroprusside
exactly.
or
So
something.
we often will start with nipride or nicardipine, so that while it's changing, we can turn it easily on and off.
And,
Exactly.
Just jumping on what Peter was saying about living in real life, I would like to ask in the audience of those taking care of single ventricle and post-Norwood, which teams do BT shunt and which teams do Sano?
So BT shunts, hands up first.
We do both.
Sano shunts?
We do those two.
I would say half-half, no?
Because I don't know, and maybe Ravi and people who's been doing that for a long time, I find significantly more easy to take care postoperatively of Sano patients,
that's true.
and they are more resilient. And in centers that they do less volume, it's a good way to achieve survival in interstage. So I think that BT shunts are very, very challenging, and they keep you awake the whole night long.
Yep. I think I can speak for Robbie. I think we definitely do. Our surgeons, again, there's 10 of them at our institution, but the majority of them, for a standard like hypoplastic left heart syndrome, will do an RV to PA conduit, a Sano. There are very specific situations where we'll use BTT shunts for patients who have tried to go down the biventricular pathway and have developed pulmonary hypertension. We'll use it in those types of scenarios, but we definitely lean more towards the RV to PA conduit. I don't know if you disagree, Ravi, but that's how I feel. And I do think it's much easier to manage it.
We were in the early 2000s when, early in my career, we did a lot of BT shunts, and then the shift towards really the RVPA conduit now. I would say that, you know, when the surgeons were doing BT shunts, they were very successful. But, you know, RVPA conduits, as you say, are more hemodynamically tolerant. They tolerate perhaps a little bit more low cardiac output. And the question of, you know, coronary underperfusion is gone. And so there are lots of certain advantages to that.
I also think the SVR trial showed that depending on which one your institution did is the one that you were better at. And so the more of whichever one you do, the surgeon volume of that had the better outcomes. And so I think even though we saw that, you know, in the first 3 months, the RVPA conduit had less complications, but there were definitely factors, including the surgeon volume of which type of shunt they were using, that affected that.
There is a political comment in Spain that say that it's a BT shunt will die on you overnight, and an RB2PA conduit, you have to be a very bad intensivist to let him die.
Well, I agree with you, but I think we simplify it maybe sometimes a tiny bit, because in my previous institution we started with RVPA conduits, and for that to start for a surgeon who has not that much experience, I think it's also sometimes difficult to get it right. It was sometimes a bit not deep enough into the right ventricular wall, so it has obstruction, especially when they are not filled enough, you know, that the relaxation time is not big enough, and then you had problems with pulmonary vascular, or it was too deep in, and then it touched the other side of the wall. So I think when it's done right and with a great experience from the surgeons, I agree, you must be a bad intensive to let the patient die. But if you start with it because you've heard it now and you have ordered all this valved RVPA conduit and you start it tomorrow, you may run into trouble because your surgeon is not very well used to put this conduits into the right ventricle. And I don't know if you see right ventricular problems with the ventriculotomy at some points too, because that can be a problem as well when you start with it. You have a ventriculotomy for the only single ventricle. So
yeah, we certainly see it's how much that plays into low cardiac output syndrome after with the ventriculotomy. I certainly think it plays a role.
We have two questions online. One is, what about the use of levosimendan in the postoperative Norwood period?
So I have to say I don't have a lot of experience with that. It's not FDA approved in the United States, so we only have it for compassionate use. So I've never used it on a patient, but yeah, I'm happy to hear how people use it in Europe, because we just don't have it available.
Any experience? We didn't use it in Berlin either.
I think we all know when the child comes out on ECMO and is very bad, and as last chance, people in Europe, as we have it available, would probably give some levosimendan, but there's no evidence or trials, so it's a last resource, try and error, and I'm sure it works without levosimendan or with levosimendan. I'm overdoing it, but there's no evidence of levosimendan in those children.
And one more question on phenoxybenzamine.
So we don't use it at Boston Children's. Certainly, I think before Milrinone became more popular, I think people were using phentolamine, phenoxybenzamine. There are studies out of Children's Wisconsin that used it in the preoperative, in the bypass period, gave a loading dose of that, and actually on this protocol, I think that the patients also did get loaded with phentolamine, I believe, for this protocol, which is similar in alpha adrenergic. As a person who is philosophically in the low SVR camp, I like it, but certainly you may have to you may be in if you do have profound hypotension in the postoperative period, you may be limited in what you can do for that, but I am philosophically in that camp, so.
I'm so sorry, but we take one last question. Yeah.
Sorry.
How often do you need to go back to the OR and clip the BT shunt or sinus shunt or downsize the BT shunt?
I would say it's not infrequently, but also not often. It's probably, maybe 20, around 15 to 20% of the time, where we'll Especially, I think in the cases where that's happening, we have a sense that there may be an issue, and so the patient comes out of the operating room with their chest opened, and we can then, after we let them settle out from their low cardiac output syndrome, we often will then close the chest at the bedside with the ICU team around, so we can all look at what the hemodynamics are as they titrate the shunt. A lot of patients will come out with the shunt, like a 4 millimeter shunt clipped to 3.5 millimeters already, kind of preemptively, but we often will, if the surgeon is worried about that, they'll often leave the chest open so that when we're closing and we can get an epicardial echo, we can see what it looks like when they clip the shunt. And so we can be part of that conversation at the bedside.
Thank you very much for this great interactive session. And I'm pleased to introduce my co-speaker, Hannes Salmon. If you read the program nicely, it still says Germany, yeah, because he has worked at the Berlin Heart Center for the last couple of years, and just 3 months ago moved to Graz to lead the division of pediatric cardiology in Graz. Thank you, Hannes, for
thank you so much for the kind introduction. And I'm also working on Eggshells because I was asked to talk about PPHN, persistent pulmonary hypertension of the newborn. Let's prepare for a hard fight. So I'm talking about something that I don't really treat myself, but I will try my best to do that. These are my disclosures, none of which are related to what I'm going to say. And this is what we all know, the fetal circulation. And the fetal circulation has some specific features, the presence of the ductus arteriosus, the foramen ovale, and the presence of high pulmonary vascular resistance, while there is low systemic vascular resistance, as you all know. And when we are born, the main task of cardiocirculatory transition at birth is to decrease pulmonary vascular resistance. And this usually happens during the onset of respiration, the withdrawal of prostanoids from the placenta, and the increase of PaO2, which then confers pulmonary vascular resistance drops and cardiocirculatory transition. So we said, let's prepare for a hard fight. So first of all, we have to know the enemy. What's going on with PVR during human gestation? During lung development, we have slightly high PVR in the canicular stage, which is elevated due to the paucity of pulmonary blood vessels. And during further lung development at the secular stage and alveolar stages, PVR decreases with the extension of the vascular network. And also with advance in gestation, there is an increasing sensitivity of the vasculature to hypoxia and endothelin also. So these all lead to a secondary increase in pulmonary vascular resistance at the end of gestation. And after birth, we expect the drop by ventilation of the lungs and clamping of the cord. We usually see a rapid decline in PVR by oxygen ventilation, endogenous nitric oxide, and prostacyclin withdrawal. Okay, so if this does not work well, then we face a situation which we call PPHN, previously referred to as persistent fetal circulation. And the two hallmarks of this circulation is that there is a sustained elevation of pulmonary vascular resistance and usually persistent hypoxia after birth through shunting. PPHN affects 0.2% of all live births, and 2% of these cases are born prematurely, so the vast majority is born term. And although there have been a lot of therapeutic developments, mortality has not really changed over the last 20 years and is reported to be in the range between 5 and 10%. So abnormal transition is the situation that we see in PPHN, and this may be caused by several reasons. On one hand, there may be parenchymal lung disease, as we see it in meconium aspiration or pneumonia. There also might be pulmonary hypoplasia, so developmental problems, or idiopathic PPHN, which usually is seen in about 10% of the cases. And idiopathic PPHN is the situation where there is no obvious cause for PPHN, but still we see high resistance and pulmonary hypertension in the newborn. So the pathophysiology, as outlined here, and we've talked about this already, is that, I can hardly see that, so I will go through this without a pointer. There may be perinatal causes that decrease pulmonary blood flow due to high pulmonary vascular resistance, which is further aggravated by hypoxia, acidosis, vasoconstrictors, and then we usually see a high pulmonary arterial pressure that is also augmented by, by the reaction of the left ventricle to the resistance-loaded RV, as I may call it. So there is septal deviation in response to high resistance and high pressure in the right ventricle, which causes LV dysfunction and thus also decreases LV preload through and pulmonary venous return, thus also contributing to high pulmonary arterial pressure. So there are several different targets that we may address during treatment, as I will show you later. As this is a session on congenital heart disease, some words on concomitant shunt disease in PPHN. If you have a VSD, there is no relevant shunting on day of life 1, as there is high PVR in the normal situations, and usually the QP to QS increases with PVR lowering. And as we see in PPHN, if there is a sustained elevation of PVR, this may reduce this shunt increase. So it's like PPHN works like an auto-banding for these patients. However, increased QP on the long run by VSD, for example, may contribute to PH later in life, which is a situation that we often see after PPHN. So if you have pre-injured vessels, like prematurely born infant who develops BPD-PH, shunts might be less well tolerated on the long run. But immediately after birth, the VSD is usually without hemodynamic significance. So we already talked about secondary causes of PH. These are the most common. So there might be meconium aspiration syndrome, asphyxia, sepsis, transient tachypnea, effusions or air leaks, and of course respiratory distress syndromes that all lead to increases in PVR, and congenital reasons like pulmonary anomalies, alveocapillary dysplasia, one of the most significant forms, surfactant protein deficiencies, diaphragmatic hernia, and genetic abnormalities that may contribute to PPHN. So this is the revised pH classification from the World Symposium in 2018. And interestingly, persistent pulmonary hypertension of the newborn is here labeled under group 1, pulmonary arterial hypertension. So this means that you have a clear pre-capillary phenotype. And there also is another group that may be interesting in this case, which is group 3, pulmonary hypertension due to lung diseases, and 3.5 is the group which is labeled developmental lung diseases. So there might be an overlap in certain cases. And also PH due to left heart disease, which would be the classic post-capillary pulmonary hypertension. In group 2.4, there is congenital and acquired cardiovascular conditions leading to post-capillary PH, and those might also contribute to clinical scenarios that may end up in clinical PPHN. In 2018, also, the hemodynamic definition of pulmonary hypertension has been revised, and the threshold has been decreased from a mean pulmonary arterial pressure of 25 to 20. Most importantly, this only applies to patients who are older than 3 months at sea level. So we cannot really use this definition for defining PPHN. So we don't really know what threshold to use to define PPHN. But the classic definition would imply hypoxemia, so there has to be some degree of right to left chanting. So at least systemic pressure might be the definition for at least severe PPHN. So there are several molecular pathways involved in PPHN, which lead to vasoconstriction, endothelial dysfunction, and vascular remodeling. Some of them might come from developmental routes, some may be acquired. And the three main molecular pathways that can be targeted by drug therapy is the NO cGMP pathway, prostanoid pathway, and the endothelin pathway. And all have been shown in animal models to contribute to PPHN. And there also is a role for oxidative stress and oxygen in the pathophysiology. One very interesting model, animal model of PPHN is premature ductal closure model. So you take sheep out of the uterus and perform hysterotomy, usually at 125 days of gestation. Term gestation would be up to 150 days. Then place the fetuses back into the uterus and with a ligated duct. And after duct ligation, you force the RV output through an immature and constricted pulmonary circuit without the chance to have a right-to-left runoff. And this implies shear stress and myogenic response and endothelial dysfunction in pulmonary vessels with subsequent smooth muscular thickening and extension. Other models of PPHN include the introduction of an aortopulmonary graft, so the other way around. This is superductus that leads to hyperperfusion of the pulmonary vessels, meconium aspiration models, chronic hypoxia models, and drug-induced models like the monocrotaline model of PH or congenital diaphragmic hernia induction by nitrophen are other well-studied models in this case. So if you have a patient with PPHN, you want to know in which hemodynamic condition the patient is. And for this, we need multimodal hemodynamic monitoring. And the monitoring goals are that we achieve adequate pre-ductal saturation, sufficient cardiac output, sufficient microcirculation, and that we have an idea of the overall hemodynamics situation, and that we recognize acute, potentially acute life-threatening events early, like ductal closure, arrhythmia development, and so on. So we need a pretty extensive setup of different techniques to achieve this, as shown here on the left side. Chest X-rays are usually helpful in defining secondary pathologies. Here are some examples from Yogan Singh. In a recent review article, they have shown that you can use the acronym tachypnea to define some of the pathologies that you might see on chest X-rays, which include aspiration, congenital anomalies, pneumonia, effusions, and air leak syndromes, all contributing to higher PVR in those patients. And the hallmark of diagnostics of PPHN, of course, is echocardiography. And there are a lot of echocardiographic markers that can be used to define the pressure load of the RV. So you can use tricuspid regurgitation jets to estimate pressure gradients. You can use pulmonary regurgitation jets to estimate pressure gradients. And what you want to achieve is to get an idea of how much pressure there is, which works on the RV, and how much this impacts RV function. So there might be high pressure load, but still the RV is working well. And on the other hand, there might be a failing RV on the long run. So you want to see function and pressure load, and you want to see how the left ventricle is doing, because there's an interdependence of both ventricles, and classically defined by the septal position. And a failing RV shifts the septum towards the left, and then you have underfilling and consecutive problems. So these are the 3 points that you want to address here. And one thing that you can use is the shunt assessment through the arterial septum and the ductus arteriosus. And the classic PPHN scenario is here on the upper right side. So you have a right to left shunt through the ductus, and you have a right to left shunt through the PFO. This is the classic PPHN physiology, but you may also encounter something like this here on the lower right part, where you have a right to left shunt on the PDA indicating suprasystemic pressures in the PAs, but you may see a left to right shunt on the atrial level. So how can this occur? This occurs if you have a severe left ventricular dysfunction, and then you have increases in LA pressure, which are then higher than the RA pressures, and you see left to right shunting here. And of course, this may also be associated with post-capillary pH, as the LA, the overfilled LA, will also affect the pulmonary veins. So these are important scenarios to distinguish here. If you encounter an infant with PPHN and you have to perform acute treatment, there are certain treatment goals. One of them is don't stress the infant, so there should be minimal stimulation, maybe adequate sedation, maybe even relaxation. And then, of course, lung parenchyma contributes to PVR, so there needs to be optimal lung recruitment in order to allow the minimum possible ventilation perfusion mismatch. There should be sufficient gas exchange, and there should be, of course, sufficient hemodynamics, cardiac output, and microcirculation in the patient. And you should avoid secondary injuries to your patient. So, as we can see here on the left side, some initial ventilator settings that may be used in PPHN.
They don't see the pointer when you don't do it here.
Sorry. Yeah. Some high frequency oscillation settings that are used as initial protocols. It's important to keep in mind that PEEP may be required to recruit the lung, but on the other hand, PEEP is our enemy in terms of PVR. So the more PEEP you give, the more you impair PVR. So optimal lung recruitment with the lowest possible PEEP should be performed. Then we talked about the interdependence of both ventricles. And as you can see here, this is a severe case of PPHN on the first day of life. You have an almost compressed left ventricle with almost no filling. This is a short axis view, the septum here.
Sorry. Maybe you just take the mic from there and then you can point better.
And it's okay. And what they did as initial measure here was to apply a fluid bolus. And the fluid bolus significantly helped the left ventricle to fill. And after a few minutes, we had this picture here. So fluid boluses might be required, but on the other hand, might be harmful if you have an already failing RV that has to handle the fluid first. Optimum oxygen saturation targets are a question of debate in PPHN. So there has been a recent experimental study in term LEMS with asphyxia and meconium aspiration, where LEMS were randomized to saturation target groups of 85 to 89%, 90 to 95, and 95 to 99%. So, and if you look here, animals who achieved this required, animals who achieved this required the lowest FiO2 in the target range of 90 to 95. But the group with higher saturations in the range of 93 to 97 here had a further decrease in PVR, so this should be optimal in case of PPHN, while if you targeted even higher saturations, there was no further decrease in PVR, so that we can assume from this animal study that this is possibly the target range of oxygen saturations, pre-ductal oxygen saturations that we try to achieve. As we already said, it's important to avoid over-distension of the lung, because if you have over-distension of the lung, you might have a direct effect on pulmonary vessels, which you compress by over-distended alveoli. On the other hand, you might even have a steal phenomenon from air and applied INO from collapsed alveoli towards the already over-distended alveoli. So optimal recruitment is essential for decreasing PVR. There are synergistic effects of INO and surfactant in PPHN. So in this study, INO and surfactant combination resulted in lower oxygenation index after 48 hours in patients, and also in a lower death or ECMO rate in these patients. So there is synergy between INO and optimal recruitment with surfactant, at least in certain conditions. In this group, children with congenital diaphragmatic hernia, heart disease, or pulmonary hypoplasia were excluded. When to initiate INO, the usual rule of thumb is this 20-20-20 rule. If you have an oxygenation index of 20 or maybe 15, you may think about NO. How much is the starting dose? 20, the second 20, and this should lead to an increase in PO2 by 20 millimeters of mercury. And weaning is the 60-60-60 rule. Start for 60 minutes. In the weaning process, if oxygen saturations are below 60% and if the PaO2 is above 60 millimeters of mercury. So NO is well studied in neonates. What about other pH targeting medications? For NO, we have several RCTs, we have meta-analysis, and we can be quite sure that this works. The same, to some extent, is true for sildenafil, and sildenafil might have a role, at least in INO weaning, and there might also be an additional effect to INO. And we have some RCT data, at least some infants, that were included in bosentan trials. Apart from these three drugs, we only have the three pathways that we can target, which is the endothelin pathway. We've already talked about bosentan. Newer developments like macitentan or ambrisentan may have a role, but are less well studied in this situation. And we also have some new drugs like riociguat on the NO-PDE5 pathway. Riociguat is a dual activator of cyclic guanylate cyclase, but still not studied in this population. And of course, we have prostanoids. And we have milrinone. We've already heard a lot about milrinone, so I don't want to add too much. It's a phosphodiesterase type 3 inhibitor, induces vasodilation in both pulmonary and systemic arterial beds. Milrinone and INO seem to have a synergistic effect on pulmonary arterial pressure in experimental PPHN. It's lusitropic and, in brackets, inotropic in some way, and seems to be especially relevant in ventricular dysfunction. And this is the scenario that we talked about earlier with the echo, when we have right to left shunt on PDA and left to right shunt on the atrial level. Evidence to use milrinone PPHN is only based on case series and observational studies. There has been a very recent small RCT comparing inhaled versus IV milrinone, showing similar results. Prostanoids are important not only because they decrease pulmonary vascular resistance, but also because they keep the duct open, and the duct is our friend to do pressure unloading of the RV. So once all these medical measures failed, we still have ECMO, and in case of ventricular failure, we may use VA ECMO. In case of a isolated pulmonary problem with good function of the ventricles, also VV ECMO, as shown with this dual lumen cannula, may be applied. How often does this really happen? Most cases of neonatal ECMOs are for pulmonary indications in Europe. This has 60%. Only 12% are PPHN, so not that much, and the survival of PPHN is within the range of other indications, about 80%. The usual ECMO indications are oxygenation indexes above 40 for more than 4 hours, and failure to wean, severe hypoxic respiratory failure, severe pulmonary hypertension, and pressure-resistant hypotension. In case of any cardiac indications, we have to do VA ECMO, as said before. Of course, if we do ECMO, we impact long-term outcome, and possibly or hopefully we have a positive impact on survival, but some negative impacts on outcome, which include the anticoagulation management that is required, that may cause bleeding and neurological problems if we have bleeds in the brain. Infectious complications, surgical complications, and vessel complications are also seen on ECMO, of course. So this is a proposed treatment algorithm where we perform echocardiography and suspected PPHN, try to perform optimal lung recruitment with optimal PEEP, think about surfactant, and then look if there is normal blood pressure and good cardiac function. In this case, everything we do should be enough to come through PPHN. If we have normal blood pressure and cardiac dysfunction, milrinone might be an option. With low blood pressure and good cardiac function, fluid boluses and vasopressors may be considered. And in the scenario of low blood pressures and cardiac dysfunction, we have to think about ECMO and circulatory support with pharmacotherapy. And if all this fails, of course, ECMO may be an option. So in conclusion, PPHN is a failure of transition with high PVR and hypoxemia. It has several secondary etiologies, usually the majority of them being pulmonary. Current pH-targeted pharmacotherapy is based on 3 molecular pathways, NO, endothelin, and prostanoids. Only INO and sildenafil have RCT data for PPHN. We aim for minimal stimulation, optimal ventilation, optimal preductal saturation, and sufficient cardiac preload, while performing monitoring of the infant as required and define pathophysiology by echo. INO is useful in precapillary physiologies. We have to keep the duct open in case of suprasystemic pH to pressure unload the ventricle by using prostanoids. And we may consider milrinone inotropic support and advanced pH therapies and vasopressors if required, and the same is true for ECMO. So thank you for your attention, and I'm happy to take questions.
Thank you very much, Hannes, for this great overview on pulmonary hypertension. We have maybe time for one question. We run already over time, and we deprived you a tiny bit of your coffee break. Anybody a question? Yeah, go ahead. Speak loud.
Okay. Yeah, thank you for the great talk. You showed in one of your first slides that there's different shape of the reaction to oxygen and endothelin, and that at the end of gestation there is a pretty high amount of endothelin reaction. So if we see in cases the child does not respond to inhaled nitric oxide, do you have any experience in trying endothelin antagonists quite early in the course? You see, okay, INO isn't working, I have sildenafil maybe already in. Do you know anything about that in that condition?
So you mean if you encounter PPHN in a preterm infant much earlier on the curve? Yeah, it's a difficult question because of course we don't have safety data for that. So everything you do is off-label and should be used very judiciously. If you start endothelin receptor antagonists, you have a full effect after 2 weeks. So it's usually not the real medication for acute treatment. INO should be cautiously used because it alters platelet function, endothelial function, and thus might contribute to IVH rates in preterm infants. So preterm PPHN is a very difficult field, as is term PPHN.
So thank you all for attending. You have 10 minutes, unfortunately only for coffee. Then we resume here the cardiac track with how we deal with residual lesions. And we are happy if you join us again here. Thank you so much. Super done. Sorry for the pointer thing, but I thought...
Yeah,
yes, yeah.